Welcome everyone. My name is Daisha Washington and I am a program analyst at NACCHO, which is the National Association of County and City Health Officials. In case folks that are non-members are on the call, don't know. Today we have the pleasure of having Dr. Julie Dombrowski join us to discuss the highly recognized Doxy PEP study, which proved to be successful in preventing STIs amongst individuals at an elevated risk for repeated STI acquisition. Dr. Dombrowski is a co-investigator of the study and also helps to run Seattle and King County's HIV/STD program. So again, we welcome you all, and we're very excited to have this webinar today and have Dr. Dombrowski join us. And now I'll allow for Dr. Dombrowski to take it away with the presentation, and we will close out with the Q&A session.
Great. Thank you so much, Daisha. I'm really excited to be here with you all today to talk about Doxy PEP. And as you can see, I'm presenting on behalf of the study team. Annie Lukemeyer at UCSF and Connie Kellum here at UW were the co-PIs of this study. Stephanie Cohen, also at City Clinic in San Francisco, was very involved. So I have the honor of talking with you on behalf of the team today. Briefly, some disclosures. Maine Pharmaceuticals did provide doxycycline for this study, and both Cepheid and Hologic provided materials and laboratory support. So I'm going to talk today first about the Doxy PEP study, briefly review the rationale and our key findings, then discuss the results in context, what else we know about doxycycline prophylaxis for STI, and then one of the most challenging areas right now, and one that I hope will generate some discussion in this group, implementation considerations. All right, as almost all of you, if not all of you in this audience know well, we have had a massive increase in STI rates in the United States over the last decade. And the data here are shown for gonorrhea, chlamydia, and for syphilis. And although we're seeing these increases in all populations, it is disproportionately, these STIs continue to disproportionately affect men who have sex with men. So the rationale for doing this study is that doxycycline taken after sex had shown some promise to reduce STIs, and that was from a French study I'll review during the course of this as well. It was a pretty small study. It was in the context of event-driven HIV pre-exposure prophylaxis, and so we had a lot of questions about whether this would work in the context of daily PrEP in people with HIV in a US population in practice. And doxycycline as a medication is generally safe, well tolerated, and very inexpensive. We've used it for a long time in medical practice, including over a substantial period of time. And so we have a good understanding of its safety profile and tolerance. It is active against both chlamydia and syphilis, or rather the bacteria causing those infections, C. trichomonas and T. pallidum, and has partial activity against gonorrhea because of levels of resistance, not all gonorrhea and not something we rely on for treatment. So the objectives of the Doxy PEP study are shown here. First really was to determine the effect of Doxy PEP on the incidence of STIs among MSM and transgender women. And second, to determine the impact of intermittent doxycycline use on drug resistance, both in STIs, those three key ones we just talked about, and other bacteria in the body. So the design of the study is shown here. This was an open label study. So really importantly, people knew whether they had active drug or not, and were randomized, those on the doxycycline arm, to take 200 milligrams as post-exposure prophylaxis within 72 hours after condomless sex. So really what we were encouraging there was taking it ideally within the first 24 hours, but up to 72 hours. Inclusion criteria are shown here on the left. This was in people living with HIV and in people who were on PrEP, who'd had at least one STI, including chlamydia, gonorrhea, or syphilis in the past year, and condomless sex with at least one cisgender male partner. The people were randomized in a 2-to-1 fashion and followed every 3 months for 3-site GC and CT testing, as well as RPR testing. The baseline characteristics of the population are shown here. So some things to note: there was some slight differences in the population age of people living with HIV, although those weren't statistically significant. You can see the proportion of people who were Black or Asian Pacific Islander, shown on this slide, or other races, and Hispanic Latino was roughly a third, 30% of the population. The vast majority were cisgender men, with some 19 total people who identified as trans women or gender diverse. The STIs in the past 12 months that qualified people for the study are shown here. So you can see, especially in people on PrEP, gonorrhea was the most common, followed by chlamydia, but a sizable proportion, 15 or 30%, depending on the arm, had syphilis in the past year. It was a median of 9 sex partners, and really importantly, this was again a real-world study offered to people on PrEP and with HIV, and substance use was substantial in the population. 30% of the population used methamphetamine or other stimulants. So our primary endpoint is shown here, and really importantly, the primary endpoint was quarterly incidence of STIs. So as I mentioned, people were followed every 3 months, tested for gonorrhea, chlamydia, and syphilis. And once someone had any one of those infections within a quarter, that was the endpoint that we were looking at. And what you can see is that it was effective overall, 65% reduction in quarterly incidence of STIs. So I should mention here, this study was stopped at the midpoint analysis by the DSMB based on efficacy. And we've continued to enroll people, but a large part of why it was stopped and why it was effective is because the quarterly HIV incidence was even higher than we had anticipated. 31% rather in people living with HIV, and 32% in the PrEP cohort, with reductions to 12% and 11% respectively. So overall message, 65% reduction in STIs. And really importantly, each one of the STIs was examined individually. That was part of the halting criteria for the study. So there was a significant reduction in gonorrhea, chlamydia, and in syphilis. And that is what's shown here. As you can see in these bars, the colors indicate anatomic sites of infection, but I don't have yet, shown on this slide, specific statistical tests between anatomic sites. But what you can see is that with gonorrhea, substantial reduction in both people on PrEP and people living with HIV. Chlamydia, largest effect of all, 88% reduction in people on PrEP, 74% in people with HIV. And syphilis, the endpoints were uncommon, but comparable to what we see in our PrEP cohort overall. So there weren't a large number of syphilis infections. That was a statistically significant reduction in people in PrEP and didn't quite meet statistical significance among people living with HIV. Okay, well, what do we know about sexual behavior and adherence? So sexual behavior at enrollment, as I showed you, there was a median of 9 sexual partners in the last year and 5 sexual acts in the past month, with 90% of that being condomless sex. So not too surprising to many of you who interact with patients or clients, but the vast majority of people who were on PrEP or who were living with HIV and taking effective antiretroviral therapy were having predominantly condomless sex. On the study, there was no significant change in the number of sex partners during the follow-up in the Doxy PEP arm, the number of condomless acts, or the number of partners between those 2 arms. So we're continuing to do this analysis in detail and we'll present those, but we didn't see any substantial evidence of what's sometimes called behavioral disinhibition, or essentially changes in sexual behavior when people knew or thought that they were on something that would reduce their risk of STIs. Adherence to Doxy PEP was high, but not perfect. Again, this was pretty close to a real-world effectiveness study, so not 100% adherence, but still a pretty high level. 86% reported always or often taking Doxy PEP after anal or vaginal sex. Our best estimate of the median number of PrEP doses, Doxy PEP doses per month was 4, with an interquartile range of 1 to 10. So median of 4 doses. When I say doses, I want to be really clear here that that means using it 4 times. So it is a 200 milligram dose, median use 4 times. A quarter of the population used it much more substantially, over 10 doses per month. Okay, so that's the basic data on the study, and I want to move into talking about the context. And I want to just invite people, if you haven't already, please feel free to put question and answers in the box. We will be having, I hope, substantial time for discussion at the end. And I really would love to hear your thoughts and questions about the study results and other topics as we go along. Okay, so what do we know about Doxy PEP from prior studies? Well, as I mentioned, there was the study in France. That was the Hypergay study. This was the first one that was relatively small. It was an RCT of an open label extension of people who were taking 2-1-1 PrEP. Many of you are probably familiar with that, but that's a strategy of HIV prevention in which 2 doses of PrEP are taken 2 to 24 hours before sex. So you have to be able to prevent sex to take event-driven PrEP, and then 1 after and another 24 period after that. And you can see the curves in difference here, where doxycycline did substantially reduce the time to first STI with a 47% reduction and a median use of 7 pills in that study group. There was also a smaller study of Doxy PrEP, so taking Doxy as pre-exposure prophylaxis, that was published in 2015. This was a pilot study of 30 MSM, men who have sex with men, living with HIV in Los Angeles who'd had a recent history of syphilis. And they were randomized to take doxycycline 100 milligrams daily, or the control, which was contingency management. So essentially giving people cash or other monetary compensation for having negative STI tests. And even with that above the standard, that wasn't standard of care, of course, and comparing those two, there was still a substantial reduction in STIs that was driven by the reduction in syphilis. So a 73% reduction in that study. And just recently, a few weeks ago now, there was an announcement of a preliminary or midpoint halting of another Doxy PEP study. So this was the DoxyVax study I want to just tell you briefly about to give context. This was a combined study of Doxy PEP as well as the Bexsero vaccine. So that is the serogroup B, the meningococcal B vaccine, which has shown some promise in reducing gonorrhea. So in this study, people were randomized to Doxy with or without Bexsero and vice versa, 4 groups, as you can see there. And we don't know all the details of this study yet because it was just stopped and will hopefully be presented over the next several months, but there was a substantial reduction in STIs, including gonorrhea, which was somewhat unexpected in light of the tetracycline resistance among Neisseria gonorrhea there, and a reduction from the Bexsero. So we're excited and look forward to hearing more information about this study. There are several other ongoing studies of Doxy PEP that we'll learn more about over time. One really important one that I want to highlight is the DPEP study in Kenya. So this is the study in cisgender women. As I mentioned, our study, the Doxy PEP study, was just in people who were male sex at birth, MSM and transgender people who have sex with men. The DPEP study will give us information about the effectiveness of Doxy PEP in cisgender women. There's also something called the DISCO study in Canada that is comparing Doxy PEP versus PrEP among MSM, and something I believe is pronounced syphilaxis, although that looks like anyhow. Another study in Australia that is an observational cohort of Doxy PEP and Doxy PrEP. So we will learn some more about efficacy, effectiveness, sexual behavior, how people use Doxy PEP through the course of these studies. So to summarize, what do we know now? We definitely know that Doxy PEP does reduce STIs. It works very well to prevent STIs in these study populations who have a high incidence of STIs, and again, are people taking HIV PrEP or living with HIV. More than 60% reduction in each quarter. We know that Doxy PEP is effective against each bacterial STI, chlamydia, gonorrhea, and syphilis. A number needed to treat, just considering all of those infections together, was about 5, so needing to treat 5 people to prevent a quarter with an STI. And we do know, although I didn't show you the data here, that it is safe and well tolerated. Essentially, we tracked severe adverse events in the study, which were unrelated. Those that did occur were unrelated to Doxy. So we did not have any significant safety events in the first part of this study that was stopped for analysis. All right, so that's what we know. What do we know? What do we need to know? And that's what I'll be spending the next part of the talk on. But one question that often comes up, and I think is relevant as we think about these unknowns and implementation, is what the population who this intervention was designed for and designed to benefit, MSM, what do they think about Doxy PEP? Anecdotally, I think we hear about high levels of interest as people are becoming aware of this. We have a few small studies to inform this, but I suspect we'll have some more over time shortly. So one study looked at, essentially just asked people on Grindr, a geospatial networking app, whether they were interested in Doxy PEP after describing it a little bit. And there were very high levels of interest, 84 and 86%. This was published in a paper in 2019. And one thing that was interesting when we really think about the racial disparities that we see in STIs and how this could impact, either for the better or for the worse, those racial disparities, at least in this study with a select population, Black and Latina MSM were more likely to report interest in Doxy PEP than non-Hispanic white MSM. In a separate setting, the Dean Street Clinic in London, which is a sexual health clinic, there was a survey done there just on a brief population. And even back then, 10% reported having taken antibiotics to prevent STIs. So again, I want to set the stage as we go in. We have at least some preliminary preliminary evidence of interest in this intervention. And to some extent, we know that it's already starting to be used in the real world. Okay, so what do we not know yet? There's a lot we don't know. And the most important thing, and really what I think will drive our conversation about implementation, is the impact of Doxy PEP on antimicrobial resistance and beyond resistance on the microbiome. So in the arena of antimicrobial resistance, we don't yet know about its impact on STIs. We are collecting some data within the course of the Doxy PEP study. Once it stopped, everyone was offered Doxy PEP. We're continuing to follow people and collect specimens, but it's going to be very hard to prove or disprove the effect of Doxy PEP on pathogens in this short study. And I think we really will need to answer these with larger populations over a longer period of time. Really importantly, chlamydia, trachomatis, and T. pallidum do not have any existing resistance to tetracyclines. So it could develop in either of those organisms, but we haven't to date seen any evidence in the world of true doxycycline resistance among those pathogens. In gonorrhea, there's absolutely tetracycline resistance, and I think it's unknown. It's certainly plausible that people taking Doxy PEP, that could drive more doxycycline resistance in Neisseria gonorrhea. And so then we need to understand the extent to which that happens and how important it is, since we do not rely on doxycycline for gonorrhea treatment right now. And then what about off-target bacteria? So Staph aureus, especially methicillin-resistant Staph aureus, doxycycline is a medication we depend on for MRSA infections. Commensal Neisseria in the throat, another thing we're collecting in the course of this study. That's important because Neisseria in the throat can transmit plasmid genes, plasma-encoded genes to Neisseria gonorrhea that essentially incur resistance. So we need to understand what happens with those commensal Neisseria as well. And then of course the gut microbiome. This one is really tricky. We are learning a lot more about how the microbiome impacts all aspects of health, weight, mood, cancer risk. And so how an antibiotic will impact the microbiome is going to be very hard to determine, but is something we need to think about as we go forward. Okay, sorry, I just said everything on this slide on the last one. Pardon me for that. All right, we've got some preliminary data to show here. We are in the process of analyzing this and giving more information. What's really been difficult is collecting the breakthrough GC infections. So we have been doing this with SURGE, which is an existing CDC-funded mechanism for Neisseria gonorrhea surveillance, but only about 17% of our isolates from baseline and GC have endpoints available. So we're working to really increase this, but there is some inherent difficulty in capturing and culturing gonorrhea. At baseline, about 25% of the isolates collected were resistant. And that population level compares to 20% in the US, so pretty close to what we would expect, and upwards of 50% in France. There were, again, in very small numbers and not completion of the isolates, but you can see some preliminary data on resistance there. Staph aureus, what we're looking at is both the likelihood of colonization as well as doxycycline resistance. So at month 12 of the participants we have this data for, it was cultured in 27% of the Doxy PEP arm and in 47% of the standard of care arm. So it did seem that Doxy PEP use was associated with decreased staph colonization. Really what we care about is doxy-resistant Staph aureus colonization and how that goes forth into clinical infections. That percentage overall was comparable in the two arms, again, with all the caveats of small data, not a long period of time. So we really have a trade-off between the amount and type of antibiotics used. So I think one thing we really need to think about is what is the comparator? So when we're thinking about people using Doxy PEP and getting it to this relatively small but very important population, the comparison isn't no antibiotic use. The comparison is antibiotic use for STIs, for empiric treatment of STIs, and of course for other infections. So we really need to understand what the trade-off is here. With the prevention in STIs, can we actually reduce antibiotic use or reduce types of antibiotics? So the doxycycline overall, again, our best estimate is 3% of days during follow-up in the standard of care arm. So that was the non-Doxy PEP arm, 3% of the days they did get doxy, presumably for treatment of chlamydia and syphilis. And the ceftriaxone use was 50% lower in the Doxy PEP arm. So we are going to try and understand this more, but again, just want to set the framework for thinking about the comparison here is not no antibiotics, it's different antibiotics, and we don't yet know enough about that. Okay. All right, so let's move into talking about implementation. So the state of implementation now, this is actively being discussed. CDC and NACCHO are planning a consultation with several experts, leaders in the field, representatives of community, public health practitioners to talk about these results and talk about implementation guidance for Doxy PEP. The only area that I am aware of that has so far issued county level guidelines is San Francisco. The Department of Health there did release guidelines in October that recommended Doxy PEP for cis-MSM and trans women who essentially met the study criteria, those who had condomless anal sex and had at least one STI in the past year. The guidelines went even further than that and recommended offering Doxy PEP to cis-MSM and trans persons who report having multiple partners in the prior year, even if they hadn't had an STI. So in most areas, we do not yet have, including where I work in Seattle-King County, this is really under active discussion. And in most areas, we don't yet have clinical or county level guidelines either. So the extent to which Doxy PEP implementation is occurring is really on an individual case-by-case basis, discussion between clinicians and patients. So what do we need to consider moving forward with implementation? I think in terms of thinking about the individual patient getting Doxy PEP and the clinical issues involved in that, implementation here is actually pretty straightforward. The other implementation questions that are difficult are outside of this encounter. I think it should be integrated with HIV care or with PrEP care. In general, if someone is at substantial risk for bacterial STIs, and they don't have HIV, they are also at risk for HIV and should be on HIV PrEP whenever feasible. Doxycycline is extremely cheap. So unlike many other interventions, which notably to me as a public health HIV STI person, things come to mind around HIV PrEP when it was first rolled out, around long-acting injectable PrEP, long-acting injectable for antiretrovirals, all of which cost is a really significant consideration. We don't have that here. Doxycycline 100 milligrams is extremely cheap. 340B price is 6 cents per pill. Okay, counseling points. I think we can embark upon shared decision-making with patients, and we need more tools for this, but we can talk about the knowns and unknowns, how to take it, and the side effects. Again, those are well known, and people do need to take it with a full glass of water to prevent pill esophagitis, not lay down immediately afterwards. We can counsel people about sun sensitivity. And one recommendation is starting with a 30-day supply with one refill. And for now, the follow-up should really be the same as all of our existing screening, which is typically 3 to 6 months for people at substantial risk of bacterial STIs. Do any laboratories need to be monitored? I think the answer to that is no. Again, I didn't show you all the data here, but we did monitor LFTs and CBCs in the study population. We didn't have significant adverse effects. We're looking at the finer details of that now. I think it's worthwhile considering LFTs after 1 year if someone is on Doxy PEP, but it does not require baseline labs. So this part, we need tools, but again, I feel it's relatively straightforward. To the point of tools and to the extent that this is implemented, which is still the bigger question, I think we are absolutely going to need to do some provider capacity building and training. So just like with HIV PrEP, which you can see some example documents there, that's about HIV PrEP, not Doxy PEP, we're going to need some short, to the point, straightforward, easy to read guidance for clinicians and prescribers. And the same for patients. And one early Doxy PEP implementation sheet that's been drafted is shown there on the left. For those of you who have or work with, everybody actually has an PTC in their area. CDC does fund several organizations to provide provider capacity building assistance and technical assistance through the prevention training centers. And I think the PTC is likely to play a key role in this aspect of Doxy PEP. So the more difficult issues, and what I don't really have all the answers for, but I'm hoping to present to you some of my thoughts. I think we've only got a few slides left, and then really spend some time, I hope, in discussion. Who should be offered Doxy PEP? Is it the study population? Is it a broader or narrower population? How will we identify people for Doxy PEP? So right now, it's mostly on the basis of people coming to a clinician and seeking it out, which will, I think, by its very nature, exacerbate disparities in STI rates. So how will Doxy PEP impact health equity? How can we implement this in a way proactively that will address and consider racial ethnic disparities in STIs and how to combat those? I think there are some implications of recommending Doxy PEP versus offering Doxy PEP. So when we talk about our guidance for local jurisdictions or clinics, I think this is an important distinction. In what I'm meaning here is recommending Doxy PEP is to me like recommending an antihypertensive for someone with high blood pressure, that we can really say that is a place where we think we are recommending it to patients, still of course doing shared decision making, versus offering, which is really, here's something that's available, here's what we know about it, is this right for you? So I think when we think about implementation, again, we need to pay attention to these terms. And then I don't have the answer to this, but another thing we need to really think about is how this will impact syphilis diagnosis. So the good news is Doxy PEP is making syphilis less likely, but it's certainly possible and perhaps even probable that people will have intermittent Doxy use. And when they acquire syphilis, how will this impact their titers and our ability to diagnose syphilis, which is already complicated. All right. Who should be offered Doxy PEP? This is, I think, one of the key discussions, and I personally feel that we need to move away from the pro-Doxy PEP, anti-Doxy PEP, and I think most people are. It is being used in the real world. We do have this evidence. So the question is, who should we offer it to? And I think the study eligibility, as we think about it, to me, it's helpful to think of where are we on this spectrum. So there are the characteristics of people who are enrolled in the trial who had bacterial STI in the past year. And we could go broader, like the San Francisco guidelines recommended, offering to people with multiple sex partners, even in the absence of STIs. And you can imagine many ways we could go broader. That I think will have the advantage of meeting patient demand, which I think is there and is likely to grow over time, but has perhaps below standard antimicrobial stewardship. So we need to think about that balance. We could, on the other hand, go more restrictive. So we could say we really want to prioritize this for the group that's at the highest risk of syphilis, if we can identify that group. And perhaps that's where we think we're going to get the most bang for our buck in terms of public health benefit. So that could, in theory, maximize the benefit to risk ratio, but we don't really have sufficient evidence for using a more narrow population, and really importantly, I think, our ability to predict. Yes, we would all like to be able to have reliable predictors of someone who's going to benefit from this the most, and we don't have a lot of validated ways to do that. There also is the downside of stigma. So I think we have found this, the broad we, in some areas with HIV PrEP, and more recently for the monkeypox vaccine, Jynneos, which was very limited and drove our need to use it more restrictively. And I think what many of us found was that having more strict definitions about sexual behavior, types of sex behavior, drug use, number of partners, exchanging sex for money or drugs, did create stigma for some people that limited their perceived access to vaccines, that people didn't want to have to answer all of the questions in detail in order to access vaccines. So we need to be thoughtful about that. And then complexity, like anything, the more complex we make this, the more difficult it's going to be to implement. I do think we really need to come together as a field, and I'm hopeful this will happen after that consultation, to have a proactive approach. So who should we be offering Doxy PEP to? I think without that, we really risk worsening racial disparities in STI rates and ethnic disparities. And we need to generate evidence to guide this approach, but not wait for it. So I think this is one where we need to take a program science approach of understanding and evaluating what we're doing in our different programs and generating information to inform the field, but not wait for additional studies to answer those questions in detail. And then really importantly, this needs to be tailored, of course, to local epidemiology and resources. So I completely recognize that San Francisco and Seattle, where this study was done, are not representative of much of the United States. And this is going to have to be tailored to the resources people have, what makes sense locally, and certainly many other differences that occur regionally and in the local context. Okay. So then I would like to just acknowledge the study team here and a few additional people on the next slide, and then we'll be ready to move into discussion. The Doxy PEP study team was really extensive and amazing in the clinics you can see here, both in San Francisco and in Seattle, as well as our endpoint adjudication committee, really crucial for those syphilis diagnoses in particular, and funding from NIH and the company support that I mentioned earlier in this talk. And then I just want to specifically thank many of my colleagues that have been really active in our discussions about how to implement this, and looking forward to that consultation coming soon that NACCHO is organizing with CDC. Okay, so that is what I have prepared. And Daisha, I'd love to hear if you have any questions in the chat box yet.
Absolutely. Thank you again, Dr. Dombrowski, for the presentation. As we mentioned earlier, we will, for the remainder of the webinar, transition to the Q&A part. And I will read aloud the questions that have been submitted in the chat, as we have a few there. Please do continue to send in any questions that you have as we work our way through what has already been submitted. So the first question is, what does TGW stand for? I think you used that on one of your slides.
I really apologize for that. transgender women. And I think really more specifically, transgender people who have sex with men. Sorry about that acronym. Thank you for pointing that out.
Thank you. And another question we have here is how close are we at getting Doxy approved as PEP?
Yeah, so that's a great question. And that is worth talking about what approved means. So there is no FDA approval process for this. So unlike an investigational drug where we do a study and the company goes to the FDA and asks for approval, this is already an FDA approved drug and you don't need, and in fact can't get, additional approval for use beyond what it's already approved for. So it's FDA approved. There's not going to be any additional approval. So the approval, as I think about it, really is in our field of scientific and public health professionals with input from community deciding how we're going to move forward. And that is what I am hopeful will come out of the consultation. I can't speak to the timeline of that, but I would welcome, if anyone from NACCHO is willing to jump in and answer that, I would welcome that.
So this is Rebecca from NACCHO. I answered this question sort of in the chat as well. So as far as the timeline, we will put out a report. So the consultation is happening in early December. We will put out a report from the consultation in early 2023, which will lay out considerations from the discussion on the consultation, but we can't speak to how long it will take for federal guidelines or recommendations to be released. Basically, they're going to listen to what happens at the consultation and then go back to CDC, put their brains together, and then come up with recommendations or guidelines, but then it has to work through the clearance process of CDC and HHS. And so that process obviously will take additional time.
Rebecca, can I ask, I think there's usually a process for public comments before something like that is published as well. Is that true?
Yep, they will be doing the recommendations or guidelines. I'm using both words because I'm not sure how they will frame it, but there will be public comment after that, after it's been released, before there's a final draft.
Thank you so much, Rebecca.
Yeah, and as we also hear of different locations putting out recommendations or guidelines, that's the sort of thing that we at NACCHO, as we learn about those things, will share out with folks. So you could sort of see what your colleagues at different local health departments or state health departments are doing across the country to inform your own decision making about implementation.
That's great. And Rebecca, are you aware of anyone besides San Francisco, any area that has put out recommendations so far?
Nope, just San Francisco.
Okay. Great.
Thank you. Thanks, Rebecca. All right, next question is, it was mentioned that some participants acknowledge using dangerous substances, for example, meth, while on the program. Did you notice any reduction in Doxy effectiveness among substance users or worse side effects?
Yeah, so that is a great question. And I have to say that we haven't had that analysis yet. So that is one of the many things, and I'm very interested in that, about whether the effectiveness is different among people who use stimulants at the time they came into the study. So I don't know yet. Please stay tuned. Many of the other sub-analyses that we've done so far haven't identified a big difference. So for example, we looked at people who had 2 or more STIs in the past year versus those who had just 1. And that group, I can talk more about that if people are interested, but there wasn't a substantial difference in the effectiveness between those 2 groups. So that's a long way of saying, I don't know yet, stay tuned. Side effects, no, not that I'm aware of. And I'm just thinking from my clinical perspective as well. There's no reason to think that methamphetamine and Doxy would interact per se. Of course, methamphetamine's not healthy for you for many reasons, but people who are taking meth can absolutely take doxycycline safely.
Thank you. And the next question is, I believe you spoke to this a bit during the presentation, but just to discuss again, what are your thoughts on Doxy PEP affecting syphilis titer interpretation?
Yes. my thoughts, I'm going to try and say this clearly, and I would really welcome any other people on the webinar who want to put thoughts in, because this is complicated. So my thoughts are really around, how do we even answer this question, and how much does it matter, right? So it's perfectly plausible that someone could, let's just imagine, have sex, get syphilis, not take their Doxy PEP that time, get a true syphilis infection, then take Doxy PEP sometimes, so they would have had intermittent incomplete therapy, and that will impact their titers. So we don't know how it impacts the titers. It's plausible. Then that means that we could miss an infection if the titer doesn't increase fourfold. But what is the impact of that, especially since people will be taking Doxy in an ongoing way? How does that at the population level balance the benefit of doxycycline preventing syphilis? And those are unknowns. I really wish I had a better answer to this. I think it's hard for me to even think how to answer that, in part because the sort of gold standard diagnosis for syphilis does usually involve serology.
Thank you, Dr. Dombrowski. The next question is there concern with antibiotic resistance occurring?
Yes. Yes, there absolutely is. And I think this question may have come in before I discussed it some more, but I think this really is the main thing that is giving people pause about using this as an intervention, is how's it going to impact antimicrobial resistance? And that is a question that I hope we can begin to answer over time, but again, is a little bit difficult to answer without broad and long time collection of specimens from people who are taking Doxy PEP and people who are not taking Doxy PEP. So yes, there's absolutely concern, and I think it's what we need to consider and grapple with as a field.
Thank you. Next question is there a sense of the amount of uptake of Doxy PEP in San Francisco?
I think at this point, it's too early to say, since it really was even just in October that recommendation was put out. I will say that anecdotally, people are in City Clinic, where the study was done, and in Ward 86, hearing from a lot of patients who are interested and feel like have been sort of reporting a high level of interest. I don't have any sense yet of whether that's just the sort of initial wave of people who may be interested and the early adopters, and to what extent that will impact interest over time. So the best answer I can give is anecdotally, at this early stage, there's a pretty high level of interest among people with HIV and taking PrEP who are MSM or transgender.
Thank you. And can you clarify again what a dose after an exposure would be?
Yes, thank you. That a dose after an exposure is 200 milligrams. So since we use in practice 100 milligram pills, that would mean a double dose, essentially taking 2 pills after sex, ideally within 24 hours, but up to 72 hours after the sex event. And we did ask people in this study not to take it more than once a day. So that didn't happen a whole lot, as you saw, but if there was somebody who was taking it once a day, that would be, I think, a different consideration around Doxy PrEP. Sorry, I am going off again. Let me stay centered on the question, which is double dose of doxycycline, 200 milligrams, ideally within 24 hours after sex.
Thank you. And have there been considerations of doxycycline use in women who become pregnant?
Yeah, so that's a great question, and wasn't relevant in this study, but will definitely be for the DPEP study. And what I will say about that is that there is sort of a tradition in the field and recommendations of avoiding doxycycline in women who are pregnant. But 2 things. One is that early in the course of pregnancy, which is, here I'm using that term as before a person knows they're pregnant, there is very little risk of doxycycline, because we often think of tooth discoloration that happens in the 2nd and 3rd trimester. So there's very little risk early in pregnancy. There have been some questions even of the extent to which it is unsafe later in pregnancy, but staying focused on that early point, the DPEP study isn't actually even routinely monitoring the study participants with pregnancy tests. So certainly if a woman becomes pregnant, knows she is pregnant and is continuing with the pregnancy, I believe they are stopping the Doxy PEP, but they're not routinely looking for pregnancy among the participants.
Thank you. And how can not waiting and needing to know affect resistance and microbiome? I'm sorry, I might have to ask this participant to pose the question to the group. Reva Katz, if you're on, do you mind reading your question aloud? Okay, we can circle back. I'm not really sure what the question was asking. The next question is, since syphilis and GCCT are problematic in women of childbearing age, is there any discussion of putting high-risk cis women on Doxy PEP? And if so, how will we approach women potentially taking Doxy PEP in early pregnancy?
Yeah, that's a really excellent question. And I think this is part of what will be discussed at the consultation. I think that sort of just to point out different perspectives that I have heard. One perspective is, let's not offer Doxy PEP to cisgender women until we have evidence of its effectiveness and safety in that population, which will come from the DPEP study, hopefully in early 2023. Another perspective is, we could offer Doxy PEP to cisgender women with a discussion of the risks and, again, shared decision-making with individual patients. So I think opinions on that point range widely. But we will hopefully have some data to inform that in 2023.
Thank you. And will we be able to share the PEP information sheet that you shared on this in the slides?
I think so. If you don't mind, let me just ask. I think that came from Annie Lukemeyer, and I assume so, but I would just like to ask her and make sure.
Excellent. And the next question is, are there any studies in other regions for clients and community?
Any studies in other regions for clients and community? I think what this question means is around the client and community perspectives on Doxy PEP and interest in that. So if I'm wrong about that, please feel free to type a clarification in. I think that there surely are, and that I don't know about them, but I hope that they're happening. I really haven't heard of others, but I suspect often what happens with a new intervention is there will be some sites that start incorporating this question or doing small surveys to understand patient interest in this topic. I would be really interested in how this varies geographically. I think we saw with HIV PrEP, for instance, that in some areas there was much more of a stigma about PrEP, where in other areas it was almost a stigma of not taking PrEP. It was really quite different in different regions. So I hope we will learn more about that. And I don't know of details of ongoing studies, but would encourage anyone here to do those.
Thank you. We have a few questions left. The next one states, we have very low HIV numbers in our jurisdiction and state, but alarmingly high syphilis numbers in all genders and sexual orientations. Is there a chance this will be recommended outside of MSM HIV groups?
Yes, I think so. I think for MSM and transgender women, we have the data from this study and from others to support offering this as an intervention. For cisgender women and for cisgender men who have sex with women only, we don't yet have the data to support that. And there's certainly, I recognize, I'm not sure if this is applicable to the region where the questioner is, but in many parts of the United States, we are really seeing syphilis skyrocket among heterosexual populations and really grasping at what are effective interventions there. So I think that I am hopeful that this could be effective in that population. What the uptake will be, I don't know. I think that's the big question. So much of the syphilis epidemic outside of the MSM community, realize I'm making some generalizations here, but a lot of areas have seen that is really increasing among people who are living homeless or unstably housed, who are injecting drugs, who are especially having high levels of methamphetamine use. And so the question is that a population who we can reach? Would they want to take Doxy PEP? I think we've struggled with HIV PrEP in that population.
Thank you. And I think this next question, you may have already spoken to a bit about syphilis serology, but it's asking, why isn't there a Doxy PEP study that includes syphilis serology?
Oh, so to be clear, our study absolutely included syphilis serology. People had syphilis serologies done at every single visit, and we are trying to recover T. pallidum from buccal swabs and genital swabs and blood. So absolutely, it is in every Doxy PEP study there is, including DPEP. The challenge is answering that question about how Doxy PEP use will impact diagnostics is hard, because to answer that question, you have to have a gold standard to say this is definitely a syphilis diagnosis and the serology didn't find it. What we don't have is that this is definitely a syphilis case without the serology. So we've got the serology data. It's still hard to figure out how to answer this question.
Okay. The next question is, as you stated, PrEP participants are very well informed, and I anticipate persons requesting Doxy PEP before guidance is published. Is there any reason one shouldn't provide Doxy on an individualized basis?
Right, so I will say, I'm just going to give you my personal opinion here, and you would get different opinions from other people. I personally think it is totally reasonable to prescribe Doxy PEP. I have done it with some of my own patients. I'm a primary care provider for people with HIV. I do have that individual discussion with them about what we know. It prevents STIs, reduces it about 65%. What we don't know, which is largely around how it will impact antimicrobial resistance in the microbiome, and talking to them about their sex patterns and how they would use this. I think that on an individual basis, it is perfectly appropriate to prescribe Doxy PEP after having that discussion and shared decision-making.
Thank you. And then we have one last question. Just wanted to remind folks, we will be wrapping up at 2 p.m. Eastern time. So if you do have any additional questions for the remaining few minutes, please do submit those now. But I see one more question right now in the chat, and it reads, the presentation spoke in one of the slides of not waiting until all data is available before proceeding, but in another, it acknowledged how much needs to be known about resistance effects or effects on the microbiome. How do we do both simultaneously?
Yeah, so that is an excellent question. Thank you for clarifying that. So when I said I think we need to not wait for additional studies, I think what I mean and what I'm thinking about there is we know that this is an effective intervention for STI prevention. It's the first new thing we've had in a very long time. I think we need to deploy this effective intervention, and I think we need to try to understand and collect data to evaluate it. So for example, on the topic of who should get Doxy PEP, I think there will almost certainly be some areas and some clinics that will promote it widely, and some that will really use it more restrictively. And understanding when we use it more restrictively, what is the uptake? How large is the population? How does that change the demographics of the population we're offering it to? And what is the better strategy? I think the antimicrobial resistance data, similarly, it will take a long time and large numbers to answer that question. And so we won't have a randomized controlled trial that will definitively answer it. It's very difficult. It's impossible really to prove the absence of an effect. So we'll get some data from this study, but we need to ideally find ways to collect specimens from people who are on Doxy PEP in the real world, For instance, looking at gonorrhea breakthroughs, right? That is one where we already have a mechanism to capture the gonorrhea and understand the antimicrobial resistance. And so that's where I think I'm trying to get with. We shouldn't wait for additional studies to really nail down who should get Doxy PEP or how it's going to impact antimicrobial resistance, because we have an effective intervention and some of those questions will need to be answered in the course of real world use and program evaluation.
Thank you. And one additional question was just entered into the chat, and it reads, should we add this to our sexual assault protocols?
You know, that is such a great question that, believe it or not, I have not thought about yet. So I don't know the answer. And I guess what I'm thinking is this probably depends a little bit on what your local practices are. So for example, I know when I see people post sexual assault, often who've come into the emergency room, our emergency room right now does give empiric STI treatment. And so I think the question is, instead of ceftriaxone or metronidazole for trick, if people were using that, would you want to use Doxy PEP? And I don't know the answer to that question. I would have to think about that a little more. It's a good question and gets back to the issue around efficacy in cisgender women.
Okay. All right. Well, I think those are all the questions. We do have a few minutes left, but I think if there are any other questions in the last 4 minutes, this is folks' last chance before we wrap up. Let me see this. Okay, here's one right now. Would you recommend usage in our emergency departments and high-risk groups?
Okay, so I interpret that to mean for people who are coming into the emergency room for any reason, should we be offering those folks Doxy PEP? And I guess what I would say is two things. One, I do think we need to wait for the CDC and NACCHO implementation guidance before I can feel comfortable saying we should be doing this at a population level, because I do think we need to be thoughtful about that. The other thing I'll say is emergency rooms are just a hard place, as I'm sure the questioner knows, and people have found some things to be effective, but it is really challenging and important to try and implement things like routine HIV testing, linkage to PrEP, linkage to Doxy PEP. So I think that's another interesting question to think about in the future, is can we leverage what we've learned from routine HIV testing and efforts to do HIV PrEP or MOUD treatment and put Doxy PEP on there? Great question. Sometimes with recurrent affections, yes. Yes, I think, Paula, I think you were the one who asked about the emergency room. So I think you're talking about if someone's coming into the emergency room frequently and having STI testing there and then not getting follow-up, should they be offered Doxy PEP? And I guess how I would think about that initially is that if you have someone in that situation, first, when you're seeing them at the point of care, you may want to consider just doing empiric treatment like we do with epi treatment. And then I think it's a question, sort of how I would think of people coming into PrEP program or sexual health clinic about whether it makes sense to offer them Doxy PEP as well.
All right, well, we are at time. And so I just wanted to say thank you so much again to Dr. Dombrowski for this amazing presentation. And also thank you to all of our attendees for joining us. Just want to let folks know that we will send the recording to you all, as well as, if it's okay with Dr. Dombrowski, the slides. Is that okay to share?
Yes.
Okay. Okay. All right. So we'll share the recording as well as the slide with all participants following the webinar. So again, thank you all. Thank you, Dr. Dombrowski, and hope that everyone has a great rest of your day and week.
Thank you all so much for having me, and thank you, Daisha, for facilitating this.
All right. Thank you so much. Take care.
Bye-bye.